Today's topic is head injury or craniocerebral injury. So, what do you mean by head injury? Head injury is a broad term that describes a vast array of injuries that occur to the scalp, starting from the scalp, skull, then brain, and underlying tissues and blood vessels in the head. So, you have to write when you are asking the question or essay, you have to first of all write the definition. So, it starts from the scalp, then skull, brain, and underlying tissues and blood vessels in the head. Head injury is also commonly referred to as brain injury or traumatic brain injury, depending on the extent of the head trauma. Injuries can range from a uh, just a minute, minor bump on the skull to the serious brain injury. Injury to the brain is the most important. So you can see scalp wound, how it will be occurring, then fractures, how it can be in the facial region and all. So that skull is getting fractured. Then swelling and bruising or loss of consciousness will be there. Nasal discharge. So these are the indication where we can suspect a brain injury or head injury. So first of all, scalp injury. So it is the commonest one and it mostly causes severe hemorrhage if not controlled. And can be either lacerations or bruising, which confirm the head injury. Scalp hair plays a very protective role and help in the hemostasis by matting into the bones. Then rich vascular supply to the scalp helps in healing, making scalp really resilient to the trauma. In infants, mostly there will be severe blood loss resulting in hypovolemic shock. Then loose areolar tissue under Gallia poneurotica is the dangerous zone of infection. First spread freely in this layer and reaches intracranial sinuses through emissary veins. Then coming to the cross section, you can see the skin of the scalp, then periosteum, a bone of the skull. Then you can see dura mater, periosteal layer, meningeal layer, subdural space, then arachnoid and subarachnoid space, then a pie matter, gray matter. You can see the layers cross section of the brain. Just a minute, doctor, can you just pause it? Voice is clearer.
Yeah, doctor, you can continue.
Okay. So you can see the layers of the step again. Slide is not moving, no?
No, ma'am, slide is not moving.
Which one will be okay? Let's do it. You can see. Coming to the scalp injury, it is the commonest one. Simple lacerations or bruising, which can result in a into a head injury. So, in infants, severe blood flows will result in hypovolemic shock. The loose areolar tissue under the gallia aponeurotic is a dangerous zone of infection. Then first spread freely into this layer and reaches the intracranial sinuses through emissary veins. You can see the cross section of the head and brain. I think already you know skin of the first layer will be the skin of the scalp, then periosteum, then bone of the skull, then dura mater, periosteal that is having the periosteal layer and meningeal layer. Then subdural space is there under the dura, then arachnoid, then subarachnoid space, then pia mater and the gray matter. Just go through that in the because not the detail is not needed. Even this topic also just it is sometimes rarely asked for essay question. In coming to the treatment, so in most of the casualty department will get these scalp lacerations. So it should be repaired in two layers with the position of the gallia, then tied to the then the closure of the skin. So first of all, the area should be shaved as the hair is there. It can act as a foreign body and produce pus or infection. So that first of all, you have to shave that area, then infiltrated with the local anesthesia is given, then cleaning of the wound is done inside and all. You have to clean using hydrogen peroxide. Then if there is any loss of tissue, wound should be extended to provide an extra flap of healing tissue. So that is all about the any injury to the scalp. Coming to the skull fracture. So it can be divided into fracture of the vault of the skull and base of the skull. So what do you mean by vault? how the base is means below part, the other part is the vault. So vault of the skull, how it can be either closed fracture or open fracture. Closed fracture means the fracture side is not exposed to outside. So it will be remaining intact, though there may be bruising on. Then open fracture means the skull is exposed out. The fracture of the skull is exposed out through the laceration of the scalp. Mostly it will get easily infected and give way to infection. So and reaches the many and cause meningitis or even brain abscess. So first of all, we have three mechanisms explained. That is, first is the compression of the sphere, then local indentation, and tangential injury. This point is important because sometimes in essays they will ask to explain the mechanism of injury. So in that compression of the sphere, compressed against any hard, the head is compressed against the hard flat surface. So it results in linear fracture start from the point of maximum convexity to thin the area of the bone. The fracture deflects from the bony buttresses towards the base of the skull. Fracture of the base are extension of the fissure starting from the vault. So second mechanism is the local indentation. Here, closed pond fracture, depressed fracture by a large round object. Like the scalp may be bruised but remain intact and the skull become indented. Dura will be remaining intact and produced by small round object produced by a compound depressed fracture. The fractured bone is depressed and in-driven, lacerating both dura and subjacent brain. Immediate risk of infection is here also, and later risk of epilepsy due to the contracting fiber scar of the healing brain will be there. Next is the tangential. So tangential injury means will be rare and caused by tangentially directed violence, which may secure a grip on the skull and lift it up, producing a horseshoe-shaped fracture surrounding the cavity. Next, types of fracture. So it can be linear or comminuted linear or depressed. So this is a picture, depressed fracture or compound fracture. And you can see the linear skull fracture or depressed skull fracture. You can see. So first of that is the linear fracture, mainly due to the mechanism of compression. It is the commonest and is a result of skull distortion. And the fracture is continuous to the base of the skull and causes anterior or posterior cranial fossa fracture also. Fracture closing squamous or temporal bone may lacerate middle meningeal vessel and cause extradural hematoma. So you can see the linear skull fracture, how it will be a crack, like linear. Then comminuted linear fracture, most common type of fracture involving vault of the skull. It indicates a deceleration or acceleration and mainly causes the primary brain injury and indicate in certain areas the possibility of extradural and subdural hemorrhage. Next is depressed fracture. It is due to sharper trauma. Like it is also having two types, closed and open fracture. In open type, there is immediate risk of infection, and inner table of the skull is more extensively affected than outer table. So this is the depression fracture, and you can see compound fracture. Mainly, what are the complications of depressed fracture? It will result in the tear of the dura, then pressure on the cerebral cortex, underlying hemorrhage, epilepsy, then pressure on the dural venous sinuses. Treatment: linear fracture without any displacement, no treatment is needed. Comminuted fracture means contaminated fractures should be removed, detached and removed. The fragments should not be disturbed if they are not causing any brain damage. Compound fracture means prophylactic antibiotics are given. Depressed fracture, if depression is greater than the depth of the inner table of the skull, it should be elevated. Next comes the vault of the skull is over. Now comes the base of the skull. So it can be divided into anterior cranial fossa, middle cranial fossa, and posterior cranial fossa. So first of all, anterior cranial fossa fracture. In this, there will be hemorrhage from the nose. So according to the cranial nerves, you have to remember. So hemorrhage from the nose, so resulting in the epistasis or escape of CSF, cerebrospinal fluid. It is called traumatic rhinorrhea or even brain matter through the nose. So either it can be bleeding through nose, that is called epistasis, or escape of CSF, that is called traumatic rhinorrhea, or the brain matter through the nose. Then hemorrhage in the orbital cavity by the presence of ecchymosis. You could have seen black-eyed after the boxing and all, you can see now. So like that hemorrhage. So it results in the ecchymosis starting in the lower lid and then gradually upper lid. There will be subconjunctival hemorrhage, and excessive hemorrhage will push the eye forward. So here, first cranial nerve is torn and there will be partial anosmia. Second cranial nerve mostly escapes injury. Third and fourth and the first divisions of fifth and sixth may be injured at the sphenoidal fissure. Third nerve palsy produces a dilated pupil in conscious patient. So that is all about anterior cranial fossa fracture. Now coming to the fracture of middle cranial fossa. So middle means you have to understand sixth, seventh, and eighth. So you just remember 1 to 6, then 6 to 7, 8. So here hemorrhage and escape of the brain contents, that is CSF or brain matter, through ears and mouth. So first was in the nose, next now ears and mouth. So epistasis occurs if nasal sinuses are affected. Then seventh and eighth, or occasionally sixth nerve may be injured. Facial nerve injury causes paralysis of the facial muscles due to compression of the blood clots or pressure from the fibrous tissue or callus. Then eighth injury causes deafness. Then injury to sixth nerve causes internal strabismus. Then coming to the fracture of the posterior cranial fossa. So finally, posterior cranial fossa. What happens? Extravasation of the blood in the suboccipital region produces a swelling at the back of the upper part of the neck and ecchymosis at the tip of the mastoid process. So just behind the ears, you can see some blackish discoloration or ecchymosis, like hyper discoloration, like either pink or dark blackish, like how the conditions and occur, no? Like that in the severe form, that is called ecchymosis. So that sign is called important. It is battle sign. Battle sign sometimes asks for remark question. So it is the extravasation of the blood in the suboccipital region, producing a swelling at the back of the upper part of the neck and ecchymosis at the tip of the mastoid process. So it is called battle sign. Here, 9th, 10th, and 10th cranial nerves are injured at jugular foramen. 12th mostly escapes as it is protected by body purchases. So importance of skull fracture. The linear fracture is the inframus part of the temporal bone injured the meningeal artery to cause extradural hemorrhage. Then compound fractures cause infection of the meninges and brain. Then depressed fracture of the vault causes dural tear and injury to the cerebral cortex. Injury to the most of the nerves occur. In basal fracture, there may be escape of blood. Escape of cranial contents occur in the basal fracture. Basal fracture of anterior cranial fossa causes air entry resulting in aerosol, intracranial aerosol. Then coming to the brain injury. So this is all about the skull fracture. So just rewind it. And first of all, we have the first step already scalp. So that is only you need suturing of the scalp injury. Second is the fracture of the vault. So vault is divided as open and closed. Then mechanism is explained. Compression, local indentation, tangential injury. Then types of fracture: linear fracture, comminuted linear fracture, and depressed fracture. And next comes the base of the skull, that is divided into anterior cranial fossa, middle cranial fossa, and posterior cranial fossa. So that is about the skull fracture. Next, coming to inner part, that is the brain injury. So brain injury, it is classified into primary brain injury and secondary brain injury. Primary means it inflicted on the brain at the moment of impact of the injury. So at the same time of injury, the brain is affected. Then secondary brain injury due to the brain swelling or edema or intracranial hemorrhage resulting from any trauma, and the patient loses consciousness few hours after the injury. So that is called secondary brain injury. So as primary means at the impact of the injury itself, the brain is getting affected. Secondary means maybe due to other symptoms like swelling, edema, or intracranial hemorrhage. Afterwards is the a brain is getting injured. So it can be two types of brain injury as seen due to the movement of brain within the skull box, then due to localized injury to the brain against rough internal configuration of the skull or falls or tentorium is called coup or contra coup. The pressure, how it is affecting direct primary impact or secondary impact. That is called coup or contra coup. You can see the head and brain in neutral position prior to impact. In second B point, you can see initial impact from behind causing the front of the brain to impact anterior aspect of the skull. Then contracope action means causing back of the brain to impact posterior aspect of the brain. Subsequent cope and contracope injury to the front and back of the brain. This is the fourth injury, how it will be affecting the brain. Next, types of primary brain injury. So so already I will be explaining more in the notes. So here just main brain injuries are explained is diffuse axonal injury in the first one. It occurs as a result of mechanical shearing. Mechanical shearing at the gray matter and white matter interface and causes disruption or and tearing of the axons, myelin sheath and blood capillaries. Then neural damage depends on duration of survival and severity of the injury. So that is diffuse axonal injury, mainly due to the mechanical shearing and causes disruption of the axons or tearing of the axons or the myelin sheath and blood capillaries. Then second is the cerebral concussion. Concussion means temporary physiological paralysis of the function without any organic structural damage. There won't be any structural damage, but the physiological paralysis. Temporary physiological paralysis will be the without any organic structural damage. That is called concussion. So patient suddenly becomes unconscious, but for a short period of time, followed by complete perfect recovery. Patient becomes pale and covered with a cold, clammy sweat, temperature drops below normal, and the pulse becomes imperceptible. Accompanied by autonomic abnormalities including bradycardia, hypotension, and sweating. Amnesia of the event is common and varying degree of temporary lethargy, irritability, and cognitive dysfunctions. Then post-concussion symptoms also will be there, that is persisting, which can be persisting for months after injury, including the headache, irritability, depression, lassitude, and vertigo. So that is about concussion. That means there is only physiological paralysis of function. Structurally it is okay, and the patient unconscious time will be very short, and there will be complete perfect recovery. The patient first of all pale and covered with cold clammy sweat, and temperature drops to the normal below normal, and pulse also can be perceived, then accompanied by autonomic abnormalities like sweating, bradycardia, hypotension, and all. And the event that they won't remember that event, so amnesia of the event. And according to the patient's immunity or power, self power, that a temporary lethargy, irritability, or cognitive dysfunction can occur. And even headache, irritability, these are all the complications, late complications. It can occur post concussion also. Next, coming to the cerebral concussion. So, sharing damage to the nerve cells and axons superficially in the cortex and deeply in the cortex between gray matter and white matter. The hemorrhages are seen in the corpus callosum, in third ventricle, and in the substantia nigra of the brainstem. Low ICP pressure will be low, then unconsciousness is more prolonged. Patient recovers with a confusion, irritability, and delirium. The pulse will be increased and low volume when the patient is unconscious. BP will be reduced, respiration remains shallow, and muscles become relaxed. During recovery, the respiration becomes deeper, pulse increases in volume, and face becomes flushed. The patient complains of headache, photophobia, and becomes irritable and even vomits. So vomiting is a little bit complicated. Then cerebral laceration. So laceration means what? Brain surface is torn with the effusion of blood in CSF, leading to subarachnoid hemorrhage. So here the brain surface is torn with effusion of the blood in CSF, leading to subarachnoid hemorrhage. Injury of the brain surface against bony ridges and the edges of the dural septa also can occur. Common under the surface of frontal bone and tip of the temporal bone. Mostly anosmia and change of personality occurs. And signs and symptoms are similar to the contusion only. Then comes the cerebral irritation. So it occurs within 48 hours of injury. Patient is conscious but no interest in the surrounding. Patient remains curled up with the knees drawn up and arms flexed. The headache, irritability, depression, and lack of concentration, defective memory, and change of personality are expected. So coming to the sequel of the contusion or laceration. So post-traumatic amnesia, that is called PTA. That is the time between head injury and return to the previous memory. If duration less than 1 hour, slight injury. Duration between 1 to 24 hours, moderate. Then between 1 to 7 days, days means it is severe. So post-traumatic amnesia. So it can be severe as duration can be 1 to 7 days. So it can be called as severe. So another type of amnesia is the retrograde amnesia. That is the loss of amnesia for events before the occurrence of the accident. Then is the cerebral irritation. Then post-contusional syndrome, traumatic epilepsy. Then permanent damage of the center of the cerebral cortex. Example, anosmia, injury to the inferior aspect of the frontal lobe, or hemianopia and blindness in case of occipital lobe lesion, ataxia and nystagmus due to cerebral lesion. I think you will be getting so many patients like in during paralysis and all, or like stroke attack, they have fell down. So like this nystagmus and all, you can see the cerebellar lesions may be occur. So these all are the result or complication of the contusions. Either there will be amnesia, then cerebral irritation can be there, or contusional, post-contusional syndromes. I already told contusional syndromes can occur. Then any traumatic epilepsy, then permanent damage of centers of the cerebral cortex. So in that example is if there is in the frontal lobe there can be anosmia, then occipital lobe there can be hemianopia and blindness, then cerebellar lesion, ataxia and nystagmus. Next, coming to the secondary brain injury. So secondary brain injury means what? It can be because after the not occurring at the time of impact, but after some time. So it can result from a brain swelling. So initially local edema occurs, then spread to both hemisphere and causes increase in intracranial pressure and leads to cerebral compression. Second is it can be because of the hemorrhage. So extradural hemorrhage or subdural hemorrhage or subcortical hemorrhage can occur, and it can result in the injury of the brain. So it may be arterial or venous bleeding. Then brain necrosis due to edema or venous engorgement. There may be ischemia to localized part of the brain. So necrosis due to edema or venous engorgement, ischemia, that is loss of blood supply or oxygen supply is lost in localized part of the brain. So according to that thinking process or in speech like that, according to the position, there may be the complication. Then conning. Conning means herniation of the contents of the brain. Next, infection. The fractures provide portal for infection and development of meningitis, brain abscess, or subdural empyema. So, another complication is the hydrocephalus. Hydrocephalus occurs from obstruction to the overflow or impaired resorption. Next can be seizures. Raised intracranial pressure can result from seizures. Then electrolyte disturbances. So that's all about the secondary brain injury. In that cerebral compression. So that comes as cerebral compression following any head injury. The brain can be compressed due to. So what all the are resulting in compression, either edemas or swelling. Then intracranial hemorrhage or hematoma. Then retention of CSF in the lateral ventricle, failure of absorption of CSF. All this can result in the cerebral compression. So first of all, that is the most important one is the intracranial hematoma. So this part is important as each of the topic can be asked for 3 mark question. Intracranial hematoma, you can see that epidural. So epidural hematoma, you can see the dura mater, then subdural hematoma, then intracerebral hematoma. So you can divide that extradural hematoma, subdural, and mainly subarachnoid hemorrhage. So first of all, extradural hematoma. That is a collection of the blood in the epidural space. That is the between the dura and the skull. Most common site is the temporoparietal region, unilateral or bilateral. The vessels commonly involved are middle meningeal veins, anterior branch of middle meningeal artery, or posterior branch of middle meningeal artery. So you can see epidural hematoma. So between the skull and the dura. Coming to the pathology. So there will be the direct blow or cope or counter cope injury resulting in a thin temporal bone fracture, tear to the vessels, then bleeding initially outward towards the scalp and under the temporalis muscle. There will be formation of hematoma, then gradual stripping of the dura from the skull and collection of the blood. So in 6 to 12 hours, extradural hematoma occurs, which increases the intracranial pressure. So which results in the coning, that is herniation of the brain, coning of the supratentorial contents through the tentorial hiatus and shifting of the midbrain towards the opposite side, which gets injured by sharp edge of the tentorial cerebellum, then resulting in the corticospinal tract before decussation on the opposite side get injured. So hemiparesis, so that is the final result, that is the hemiparesis or paralysis, and pupillary changes occur on the same side of the hematoma. It's called Cornohan's notch effect. So that is the pathology occurring in extradural hematoma. Here, next, the clinical feature. So obviously there will be transient loss of consciousness following history of trauma or fall. Then lucid interval will be the patient presents with the confusion, irritability, drowsiness, hemiparesis on the same side of the injury. Then initially pupillary constriction, then pupillary dilatation of the same side, finally become unconscious. So that is transient loss of consciousness. After a trauma, transient loss of consciousness. So the pupil will first of all the patient will be in confusion, irritability, drowsiness, and all. Then initially first pupil will be constricted, then later dilatation on the same side, and finally become unconscious. There will be features like raised intracranial pressure, that is high BP, bradycardia, and vomiting. Then convulsions, wound or hematoma in the temporal regions of the scalp. So clinical features of extradural hemorrhage, that is a transient loss of consciousness. Initially the pupillary constriction and later the pupillary dilatation and finally becoming unconscious. Then high BP, bradycardia, vomiting will be the symptoms. Convulsions will be the wound or hematoma in the temporal region of the scalp is obvious. Then you can see the epidural hematoma, the pictures showing epidural, subdural, and intracerebral hematoma. Investigations, you have to go for X-ray of the skull, electrolyte estimation, then CT scan which show biconvex lesions. Treatment is surgical correction, then complication, post-traumatic epilepsy, meningitis, and amnesia, post-traumatic amnesia. This is a picture of bilateral parietal extradural hematoma. You can see the pictures. Next, coming to the subdural hematoma. Subdural hematoma. So it can be again divided into acute or chronic. So first of all, acute subdural hematoma. So what do you mean by subdural? There will be collection of blood between brain and dura mater. The other one was skull and dura mater. This is below the dura, that is dura and the brain. Due to the injury of the cortical veins, hematoma is diffuse and extensive, no lucid interval, and severe primary brain injury will be the hematoma may be of cup or counter cup, then immediate loss of consciousness and which is progressive. So you can see the cross section of the brain, where you can see the bleeding between the dura mater and the skull is the epidural hematoma. Subdural means between the brain and arachnoid matter and the uh, dura mater. So here convulsion is common and raised intracranial pressure will be the focal neurological deficit and hemiparesis occurs. CT shows concavo-convex lesions. Next coming to the, so that was about acute subdural hematoma. Now coming to the chronic subdural hematoma. Due to rupture of veins between dura and brain, causing gradual collection of the blood in the subdural space. So mostly it occurs in the elderly people following any minor trauma event. So clinical feature, history of trauma will be there, and there will be complaints like a confusion, disorientation, altered level of consciousness, and drowsiness. And later convulsions. There will be intracranial hypertension. Then features of coning. That is coning means herniation of the brain matter. Then investigation, CT should be there. In that you can see concavo convex lesion, then electrolytes, then blood grouping and close matching before surgery. Then electrolyte imbalance also similar symptoms can be there, and any other space occupying lesions or tumors can be differential diagnosis. Then treatment in craniotomy, then evacuation of the fluid. So you know there is hematoma, so we have to remove that fluid, evacuation of the fluid, and antibiotics, anticonvulsants for the symptomatic relief. And complications are epilepsy, meningitis, coning, and neurological deficit. Next, coming to the subarachnoid hemorrhage. So, what you mean by subarachnoid? So, subarachnoid hemorrhage mainly results from a aneurysm or hypertension or arteriovenous malformation, blood dyskaryosis, then anticoagulant drug, or any brain tumor also that can result in subarachnoid hemorrhage. Clinical features: sudden onset of severe headache with vomiting. So in this, no unconsciousness is not there, but severe headache with vomiting, raised features of raised intracranial pressure, photophobia, neck stiffness, then focal neurological deficit, eye changes that is ptosis or dilated pupil or change in the eyeball movement. Anything can occur. Then uh, then sudden loss of consciousness occur, and but first symptom is headache. Then after that, suddenly the patient is getting unconscious. Then features of the brain edema, cerebral ischemia. Next, coming to the investigation. So first of all, we have to differentiate with the using a lumbar function, so that to differentiate, because all the symptoms are related to meningitis also. So we have to do the lumbar puncture and rule out any infection in the meninges. Then CT scan, then carotid and vertebral angiogram also should be taken. So commonly, these are the early complications of head injury, like leakage of CSF symptoms, then aerosol or the cold air will be escaping, then aerosol, meningitis, fat embolism, brainstem injury, posterior fossa compression, pituitary failure. All these can be resulted from a as a complication of head injury. Then late complication, chronic subdural hematoma, post-traumatic epilepsy, severe headache, and hydrocephalus. All these can occur as a late complications. Coming to the gasco-coma scheme. This is actually so many topics are there, but selected topics which are important in for our topics or syllabus is I have covered. So this is one of the important scale which uh, which is used in any like encephalitis or any like you will be getting like chronic kidney related patients or liver cirrhosis. After liver cirrhosis, they may go for a septicemia. Like that condition you may see during your practice. So in that case, gasco coma scale is the measurement how they are finding a sudden damage, brain damage, either due to injury or like other disease also resulting in the brain death. So that brain death, how they are calculating. So eye opening, verbal response, motor response. This is important 3 mark question or 5 mark also they can ask. So eye opening, it can be graded as 4 points. That is, first is eye opening spontaneously. If just imagine a patient lying, and when we are entering to the room and asking or just calling, at that time itself, they are opening the eye. So opening, spontaneous opening of the eye. So when we are entering itself, while any movement is seen or like that, spontaneously the patient is opening, able to open the eye means that is 4 point is given. Then if we are calling loudly and to the sound only he is responding means 3. Then to pressure, like pain or pressure, just you are shaking the body or calling or just giving a pin and like that, any pressure you are applying, and that you can grade it as a 2. So spontaneous, then to sound, to pressure or pain, and then no response at all. That is the eye opening. Then verbal response, that is having, so here you can see 4, 5, 6, that 3 points, 4, 5, and 6. So verbal. So when you are asking any question, the patient is oriented, well oriented, you are conscious, and the patient is conscious means he will be well oriented. So that is getting 5 points. But when you are asking questions, they are answering but confused nature, it is a 4 grade. Then some words they are telling but not clear. Words they are telling means 3. Then some sounds only means 2. Then no response at all means 1. Then motor response. So you just asked to give a handshake. So obeying commands properly means, although if when though it is weak, also obeying correctly means it is 6. Then just trying to localize, that is 5. Then normal flexion, they are trying to do something like bending the fingers or flexion movements of the hands they are doing, that is 4. Abnormal, they are trying but it is going against their control means abnormal flexion. And extension, it is occurring when we are asking, so that is 2 and none. So when you have to write it and calculate it, so when it is coming under 8 means it is severe brain death is happening. So 3 to 8 is a severe. Then 3 means actually below 3 means it is brain death. So severe means 3 to 8, 9 to 12 is moderate, and mild injury means it will be 13 to 15. Next, coming to the management. So I have told mild, moderate, and severe. So mild, moderate, and severe means what? So first of all, you can see mainly five features you have to see. That is loss of consciousness. That is less than 5 minutes means it is mild only. Amnesia, post-traumatic amnesia, less than 30 minutes is okay, mild only. Then comma scale 13 to 15 is mild. Then no confusion in the ct is normal. And confusion less than 24 hours, within 1 day it is becoming okay means that is mild brain injury. So what you have to see next, in few hours you have to repeat the Glasgow comma scale. Then observation should be there. No need of prolonged observation. If he is okay within 24 hours means it will be okay. Then most important first line of assessment is the neuro psychological assessment. Then CT scan, if less than score is less than 50 and open or depressed fracture is the single signs of basilar fracture or vomiting more than 2 episodes. So one episode after a head injury, like small kids and all, if he if just fallen in the head and have a just a bump on the head, the patients or parents will run to hospitals. Actually, that is not needed. One vomiting is okay. More than 2 episodes of vomiting is only we should go for any CT scan and all. And mainly age greater than 65 years, usage of anticoagulants, etc. You have to go for a CT scan. Then criteria for admission: CT unavailable or abnormal with the fractures, then focal neurological deficit, or this scale is not returning to the normal scale. 15, it is not normal means you can admit. Otherwise, no admission is needed within 24 hours. They'll see okay. Then coming to the moderate traumatic brain injury, CT scan is a must, and the blood type, dose match, and coagulation studies should be taken. Evaluate other injuries. Most common is cervical spine. That is even 5% chances are there. Hence, X-ray C spine, dynamic flexion or extension view, and fluoroscopy follow up with CT after 12 hours also should be taken. Then, if there is deteriorating signs like the symptoms are increasing, means treat as a severe traumatic brain injury. Coming to the severe traumatic brain injury, urgent neurological surgery consultation after stabilization. So at that time, severe TBI means urgent neurosurgeon. We have to consult once the intubation or ventilation for the airway, then CT scan. So it should be put in the ventilator, and the intubation should be done. Endotracheal intubation should be done. Then CT scan is a must, and all the other studies like blood type, cross matching, and coagulation studies, so as to indicate for the immediate surgery should be done. Then frequent neurological test and scale should be monitored. Then IV fluid, normal or hypertonic saline, and don't overload, as sometimes the pressure may elevate. Avoid glucose or hypotonic fluid. Then hyperventilation also. So is there means the PaCO2 is less than 25 mmHg. It is critical. So less than 30 Hg means it is dangerous, hence maintain between 30 to 35.5 mmHg, but more than 45, it causes vasodilation and cerebral edema. So we have to maintain the PaCO2 level between 30 to 33.5. So then mannitol is given, this reduces intracranial pressure. When it is less than 20 mmHg, we have to give, or head up to 30-degree elevation is needed. Then maintain the pressure to 70 mmHg. So these all are the conditions we are doing in the ventilator. So that is not needed in the much detail. Then finally, the brain death. So how you can call it as a brain death when the score is below or equal to 3. That is non-reactive pupil, absent brainstem reflex. Studies when there is proof in the EEG or angiography of the cerebrum, we can prove that the brain is dead, and the blood volume that flows per unit time is also very less, means we can identify it as a brain death. So that is all about the injury. So in that, you have to give importance to the Glasgow coma scale. So according to the coma scale only, we are classifying it as mild, moderate, and severe. So mild means no need of further, just observation is needed, no need of prolonged hospitalization and all. Maybe there will be simple symptoms like amnesia and all that will be can be regained. Then moderate means we have to treat according to the CT findings. You have to go for CT and treat accordingly. Severe means first we have to rush for a neurosurgeon, and intubation and ventilation should be given. And till he is gaining the coma scale is increasing, so we have to frequently go for the Glasgow coma scale. And once it is okay, means we can go for discharging. So like that. Then that is all about brain injury in modern. Next, coming to the Ayurvedic view. So Ayurveda, as it is mostly asked for 15 marks. You have to consider about the Ayurvedic portion. So Ayurvedic portion means, Shidas. Shidas is a trimarma according to Charaka. One among the trimarmas, Shidas, Hridaya, and Vasti. Injury to any of these marma causes destruction of the life. So it is a seat of Indriya, Indriyavaha Srodhas, or Pranavaha Srodhas. So any destruction, any injury to this marma causes destruction of the life. Then Siro Marma Vikara. So 15 marks means you have to at least cover simple Ayurvedic portion also. So Manyastamba Ardita Chakshu Vibrama Moha Vicheshtanam Cheshtanasham Kasashwasa Hanugraha Mugata Gadgadatam. So all the symptoms, Mugata or Gadgadatam, Akshin Nimidinam. All these symptoms you can correlate with the our symptoms from the all the cranial fossa, anterior posterior, middle cranial fossa fractures. You can see all these symptoms are coming. Swarahani, Lala, Strava. So that is all about the Ayurvedic portion also. Next, coming to the questions. So mostly 10 or 15 mark question according to your university. So mostly it comes as a essay. So Shiro Bigada only mostly it is asked. So you have to understand that we have to write about modern in detail. Cerebral hemorrhage, injury or head injury, like that also terms can be asked. So in that types and symptoms like that alone can be given, types, symptoms, and management. Then even mechanism also can be mentioned in some questions. And for 5 mark, like extradural hematoma, subdural hematoma, subarachnoid hemorrhage. So that hemorrhage is actually asked in short form also in some questions. Subarachnoid hemorrhage. So SAH. So like that one question paper I have seen. So SAH means subarachnoid hemorrhage. Then Glasgow coma scale, that is also very important. Then these three can be asked for um, 3 marks question or 2 mark question even. So I will just once more rewind. That is, first of all, definition. That is definition. We have to. It is a broad term which is occurring where the injuries is occurring from starting from scalp. So first of all, you have to explain the scalp. Scalp injury means there is only we need to do the suturing. So that is actually two layer of sutures. Modern that part and all I have explained in notes, I think. Then scalp, then skull, then skull in that fractures, then brain injury, that is primary and secondary, and all the underlying tissues, blood vessels, and all. So that is the definition. Then first of all, scalp injury, which results in hemorrhage, and we have to do the treatment. That is the two-layer treatment. That is apposition of the gallia, then a closure of the skin. Before that, we have to shave that region so that there is no hair is into the wound. Then skull fracture either can be vault fracture or base of the skull. So vault fracture means it can mechanism compression fracture, local indentation, tangential injury. Then types of fracture, linear fracture. You can see the picture, linear fracture. Then comminuted linear fracture, depressed fracture. You can see the picture, compound fracture and depressed fractures. Then, so mainly depressed fracture and all result in the dural tear and results in the other complications of internal hemorrhage, epilepsy and all. Then treatment, linear means no treatment, no displacement. Then comminuted means that fragment should be detached or removed. Then if it is not causing any brain damage means no need to disturb. Then according to the compound fracture means it is open. So prophylactic antibiotic should be given. Then depressed fracture means it should be elevated. Then according to the base of the skull, anterior, middle and posterior. So in anterior means mostly nose related symptoms, epistaxis or traumatic rhinorrhea and all. So first cranial, second cranial and third and fourth and first divisions of fifth and sixth also may be injured. Then middle cranial means mainly first, sixth, seventh, and eighth are injured. Then in that mostly ear and mouth, there will be hemorrhage or escape of the brain matter. Then posterior cranial means 9th, 10th, and 11th. 12th mostly escapes. So that's all about the skull fractures. Then brain injury, primary and secondary is that is cop and contra cop injuries are there when the initial impact from behind causing front of the brain to the impact to impact anterior aspect of the skull. So impact is from the posterior side. So brain is going and hitting the skull, anterior aspect of the skull. Here, contract curve means causing back of the brain to impact the posterior aspect of the skull. Then both occurs means like this, contra and curve contra injury will be there. Then primary, in that mainly diffuse axonal, where the disruption of the or tearing of the axons are occurring. Then cerebral concussion, where there will be paralysis, temporary paralysis, that is temporary physiological paralysis of functions, but there won't be any structural damage. Only for a short period, the patient will be unconscious. Only the symptoms like irritability, lethargy, like that will be there. Not much personality changes and all will not be there. Contusion means here actually damage to the nerve cells and axons and like deeply it is there. Deep gray matter and white matter will be there. So there will be lower intracranial pressure and unconscious more prolonged. But he will be recovering with the confusion, irritability, and delirium. And mostly the patient complains with the headache, photophobia, and irritable, and often vomits also. Laceration means small changes extra like anosmia, personality changes, etc. can occur. Irritation means it occurs within 48 hours. The patient is conscious but not interested. Like you want to curl up with the knees drawn up and arms are flexed. Headache, irritability, and change of personality. That is the main thing. Change of personality is expected. Then these are the consequences: amnesia, then irritation, epilepsy, and all can occur, and this can result in, according to the lobe affected, we can result in anosmia, hemianosmia, blindness. So you can see these all the symptoms are coming in the Shiromarmapika, the Lakshana. Then coming to secondary, these all can result in like swelling. It can result in later brain injury, hemorrhage, or necrosis. So in that hemorrhage is the important thing. That is the intracranial hematoma, extradural, subdural, and subarachnoid hemorrhage. You can see the extradural hematoma. You can see that is collection between the epidural space between dura and the skull. Then pathology is not that much important. Just Cornohan's notch effect is there, so which result in the hemiparesis and pupillary changes. Then clinical features: transient loss, that is slowly their pupillary constriction, then dilation of the on the same side, then patient become unconscious. There may be convulsions also. Then subdural means no lucid interval. There will be connection between brain and dura, and immediate loss of consciousness and progressive loss. No, longer loss of consciousness will be there. And the CT also concavo convex lesion here. Chronic means patient altered level of consciousness, confusion, and all will be there. Hypertension will be there. Then subarachnoid hemorrhage means mostly raised intracranial pressure and sudden onset of severe headache with vomiting, photophobia, then sudden loss of consciousness. That is about this one. Then early and late complications. These also ask for 5 mark questions and tests. Complications of head injury. So you can divide it as early and late. So in that early means because of the leakage of cerebrospinal fluid or aerosol, then meningitis, fat embolism, then brainstem injury, posterior fossa compression, pituitary failure. All this according to the site of injury, complications can occur. Then late complication: chronic subdural hematoma, then post-traumatic epilepsy, headache, hydrocephalus. I think you'll be knowing about hydrocephalus. The fluid is accumulating. Hydrocephalus also in, I think Paumara already would have covered. Then Gasco coma scale, that is important part in this for short question. Eye opening, verbal response, and motor response, which result in it can be classified as 3 to 8 is the severe condition, moderate means 9 to 12, middle means 13 to 15. It is not only for the normal brain injury, but also for, because of the any other disease which resulting encephalitis, meningitis, and all, where their patient is going to a coma stage, and the brain death is occurring. So according to the scale, classified as mild, moderate, and severe. And brain death is when it is equal to 3, non-reactive pupil. Then according to Ayurveda, it is a Shiro Marma Vikara. So that's all. In 1 hour only.